All right, well, we're going to go ahead and get started. I appreciate y'all being here and looking forward to the conversation. To start things off, just so for an overview, what we're going to do is probably some intros. We'll fly through those quickly, dive into the topic here, and then we'll finish with 10 to 15 minutes of questions. So feel free to be thinking of those throughout the session and ask those at the end, and hopefully we'll have some good answers. But for those of you that don't know me, my name's Matt Chappelle. I am an investor at Frisch Cressy Ventures. We're an early stage healthcare venture capital firm. And before getting into investing in finance, I actually did business development for a behavioral health hospital under the UHS, or Universal Health Services umbrella. And so behavioral health is near and dear to my heart, and excited for the topic here and discussing value-based care. And so with that, we'll jump in and we'll maybe start here with Jill, if you want to give just a very brief intro and relevant experience, and then we'll keep moving down the line.
Thank you. I'm Jill Fitzgerald. I am an LICSW by training and work for Confidant Health. I oversee all of our clinical operations, and we are a digital health platform as well as a multi-state provider network serving adults with mental health and addiction needs and in the virtual setting. So we're very focused on quality. That's definitely our North Star. And so aligning the interests of clients, providers, and payers to deliver measurement-based care at scale.
Hi, Kate Hobbs. I'm the CEO for Author Health. We're a company focused on serious mental illness, substance use disorders, and dementia for Medicare Advantage and D-SNP populations. We participate in value-based payment models. So I'm here from both the provider side, and then for the last 15 years or so, I've worked for health insurance companies across Medicaid, Medicare, commercial, building and delivering value-based payment models as well. So I'll probably wear both hats today.
Hi, I'm Patty Gibson, and I'm an adult psychiatrist, the medical director for Arkansas Blue Cross Blue Shield, which I've been there 1 year now. I am a clinician by background, an adult psychiatrist, and so that is really informing a lot of what I have to say. And I participated in a CPC Plus initiative with Arkansas Blue Cross and 6 other payers in the state of Arkansas. And also I worked at the VA and got involved in integrated behavioral health. So behavioral health integration is my passion, and have started a nonprofit called Arkansas Behavioral Health Integration Network. So working in a value-based environment, that's actually why I'm now at Blue Cross, realizing, everything can't be fee-for-service and survive.
Yeah, I love it. Hi, everyone. Jeff Smith, CEO of Bamboo Health. Most recently, I was president of a value-based care enablement company called Lumeris, where we took capitated risks, so know the value-based care space well. Bamboo Health think of our software as a superhighway connecting a fragmented healthcare system through real-time intelligence during pivotal care moments. And we've recently launched something called Bamboo Bridge, which is a care navigation offering that's tech-enabled service that actually takes individuals during those pivotal moments and connects them with providers who need the care for their next best step. Over to you, Trip.
Thank you. Good afternoon. I know way too many faces in this room, so anyways, good to see a lot of you again. Trip Hofer, I am here today representing 406 Ventures. At 406, I spend about 10% of my time with that fund. We typically fund seed companies. I have been at 2 or 3 companies of which 406 funded us. Right now, I'm also, though, predominantly the CEO of a company called Redox, which is in data interoperability. But the reason I'm here is because one of the 406 companies that I ran was Able2, which was purchased by Optum, and that led me to run Optum Behavioral Health for 2 years, and that ended in 2023 when I then, Liam Donahue, who's right over there, asked me to come over to 406, and I started running Redox in the data interoperability space, which is interesting because a lot of what I found specifically on this topic was if you don't have the data, you can't really do a lot of this stuff, and the data is very messy. But we'll get into that later. So anyways, thank you for having me, and I guess we'll start the show.
All right. Well, so maybe Dr. Gibson, we'll start here with you, just given the payer perspective. But when you think about healthcare, the most common used term currently is AI. The second one, though, is value-based care. And we've seen it work in other specialties. We've seen it work in primary. We've seen it work and not work in certain areas. From your perspective on the payer side, maybe just orient us here at the start with how you think value-based, what's the current landscape of value-based care for behavioral health? What's working, what's not in its current construct? Will it work? What's your perspective from Arkansas Blue?
Well, my perspective is it needs to work because a lot of the best care is not going to be able to be provided with a fee-for-service environment and the way that the healthcare system is set up. So it needs to work. And the reason I mentioned the VA and a CPC Plus initiative that was a per member per month bundle payment to practices, and we saw that they were able to set up various people in their clinics, including behavioral health, as well as dietitians and other types of care coordinators. And so that worked. Well, when that transitioned to primary care first, where they ended up getting extra payments, more like a shared savings, then a lot of the programs that could bill, like behavioral health, were dropped. And so they get switched into, well, you need bill fee for service. And so that's a big problem for the providers and for the payers. It's kind of like it's hard for us to jump to that. At Arkansas Blue Cross, we are doing some value-based collaboratives, meeting with our systems and trying to help them with data, trying to analyze what they're doing, and then they do get paid in a value-based payment arrangement. We need more, and we want more, but it's still a challenge, and data is a part of it, and figuring out how we can get people to answer the phone. Like we get a lot of vendors that will come, we can help you see who needs to be part of these programs, but people don't trust the payer. And I can say that as a psychiatrist, I'm like, oh no, all y'all are trying to do is not pay me. And then as a member, why is the insurance company calling me? And then if you get this in my record, then you're going to charge me more. There's a lot of distrust. So I think value-based care, especially, it's going to have to be built on relationships and partnerships that there can be trust. So, and then the last thing I'll say is I realize people have, the hospitals and the payers have totally different, to stay in business, the payer needs to not have to spend too much money. But for the hospital to stay in business, they have to be able to get paid. And so how do we bring those two together as partners and everybody still be able to stay in business and provide the care that's needed, especially in integrated or in behavioral health?
If I could just pick up on that, I think when we talk value-based care, I don't think you can be successful going forward in value-based care without treating the underlying behavioral health conditions for these individuals. I mean, just think about it for a second. If you're a provider, to your point, you're in a value-based arrangement. These are 20% of a Medicare population. They're typically 5 times the cost of a standard individual. They are within the 5% that drives 50% of the costs. They're some of your highest flyers. So you can't be successful in value-based care unless you're actually attacking the underlying conditions that these individuals have, and you spend all this time focused on, I'm treating diabetes, I'm treating their other, heart disease, but if you don't get to the bottom of their other conditions, all that can go away with, a condition incident or whatever might come from that. So I just think it's fundamental in value-based care, and they have to be connected. So you need to think about an integrated, whole-person approach to these individuals, their behavioral health conditions, and the comorbidities that they have.
And I would just add something to that that's sort of been a theme of the other discussions I've been listening to while I've been here, is that providers delivering the care are burnt out. And so they're really in this place where, I know when I was in my graduate program, I was not taught about measurement-based care. And so we really have to support providers in being able to deliver this and to leverage the technology to do that in a way that doesn't add burden to the care. And so that's something we're really focused on, is how do we support providers in, delivering measurement-based care, seeing this as a treatment tool that's actually advantageous to them, and then ultimately sort of supports the individual in achieving those milestones and, living their best life, which is the goal of what we're doing here. So.
That's great. Kate, from your perspective, just building a value-based care business focused in the MA space, what have been some insights that you've seen since you've joined and started Author just what is working currently in the current construct, and how can we continue to do more of that?
Yeah, thanks for that question. So I think a couple of things. So one is recognizing that providers exist on a continuum, and this is true in all of healthcare, not just behavioral health, of readiness to be able to take on and manage risk. And so from a payer perspective, being very thoughtful about developing and delivering value-based payment models that allow providers to join in at whatever level of maturity they are in terms of being able to take risk. And so what I mean by that, a lot of behavioral health practices are 1- and 2-person practices, right? Like the majority of a payer's network actually is very small practices that are operating on very thin margins. And so their ability to take downside financial risk is really challenging. And so for those groups, that's where a fee-for-service model with a pay-for-performance kind of quality bonus is really beneficial. And then you have other providers where, you know, they are more mature, able to manage downside risk, and that's where you can get really interesting models where you can use claims to identify patient populations with certain behavioral health conditions in a certain geography. These providers may even be able to care for that whole population and take accountability, both financial accountability and also accountability for health for that whole population. And what we know from the rest of healthcare is that the faster and also sort of more how comprehensively we're able to help providers move to that full accountability and population risk, that's where we're really going to see our behavioral health system change and grow and transform. But again, we have to recognize where we are today, allow providers to get on this glide path, and then support them to move along to those more robust models.
That's great. One of the things, you know, when we think about value-based care in any specialty, but such a crucial component of that is being able to measure outcomes and deliver cost of care reductions and be able to point to it and improvement. And this concept of, you know, outcome-based or measurement-based care in healthcare in general has probably lacked and farther behind. And then you take behavioral health, and it's even farther behind in terms of our ability to demonstrate outcomes. How do we as a society or as behavioral health industry, how do we begin to think about measurement-based and outcome-based care as we think about contracting and being able to show cost levers and cost of care reduction, especially when behavioral health is such a longer term, right? You might not see these outcomes for years down the road. What are some of y'all's perspectives on just how do we begin to align the industry around specific outcomes or specific measurements to be able to show value-based care is moving in the right direction?
Yeah, I've got a perspective. Definitely agree with the point around, you know, a spectrum of those that can be comfortable taking risk. And I think quality measures are very important in that, and making sure there's more standardization there. There's 2 points I guess I would add to this. I think one is to the extent that behavioral health providers can be part of a value-based care pool or payment plan, we've seen that work really well. So as a primary care physician, when I have attributed lives, I'm bringing in behavioral health providers as part of that pool payout, and so I have alignment with those individuals. The second point I would add is back to the metrics. We can't forget that these are some of the most fragile, most needy individuals that we need to be caring for in the healthcare system. And there was a big move with version 24 to version 28 for a reason in appropriate reimbursement under Medicare Advantage, is because there was an acknowledgement that you need to get appropriate reimbursement for these individuals. Without that reimbursement, it's very hard to make that infrastructure investment to provide the care for these individuals when they need it. And it creates a flywheel for you to be able to take more and more risk. Because let's face it, taking value-based care risk requires infrastructure. And what's appropriate here is that Medicare Advantage there's lots of flaws in a lot of models, but it has a structure where you can get appropriate revenue, quality payment, and cost savings, which I think is the right model when you're trying to create a flywheel to support these individuals over time. And the more we can pull this right into the value-based care speak that's out there today, there is a financing model around it, and it's going to be highly government-based, but I think there's a way to actually tackle this problem together with the attributed lives and the primary care physicians and the payers that are being collaborative and working with them.
Kate's laughing at me. The grumpy old man sits at the end of the stage. I am. So when it comes to value-based care, the first question I always ask this is both from my startup world and then being a payer at Optum. And you guys probably heard Andy Kelly speak yesterday. So Andy was like my right hand in terms of when we go contract for this stuff. So the first question is like, the definition is so widely variable. I'm like, what does it even mean? Right? That's my first problem I have with when we talk about value-based care, because everybody has a different definition of it. Most of the people in this room, probably when you think about behavioral health, you're probably going to say, well, value-based care to me is access. Did the appointment occur, and was there some improvement on some self-reported scale? Right? So, okay, like GAT7, PHQ-9, whatever you want to use, right? That's, again, the majority of you, if you're startups, right, in this world, that's how we did it, able to. And, the challenge is, like, is access really a value-based care metric? Like, is that what, like, we are measuring? And, like, okay, I guess, right? And so we were always struggling with, okay, well, how first do we define this thing? Because to me, that's a performance guarantee. Like, it's not a value-based care metric. It's like, if you can't give me access, I'm going to, ding you on fees, or I'm not going to pay you certain things. But that's not value creation. Value creation should be based on, my opinion, adherence to evidence-based guidelines. Period. That's end of story, right? Which, by the way, in our industry, behavioral health is it's like somewhat non-existent. I have a very good friend of mine who runs a treatment facility. He's written a bunch of books, and I was talking to him, and before I met with him, he came in the room, and he's like ghost face. And I was like, what's going on? He's like, well, I do a lot of CME credits for a lot of providers that are out there, a lot of therapists. And we were talking about how they go about supporting people with substance use disorder. And he's like, Tripp, I don't even know how to begin to describe the discrepancy in what people think they should do and how they treat these individuals. So like when we start talking about value-based arrangements, like how do we get to the real core of the topic, in my opinion, which is like, are you practicing evidence-based medicine? Like, period on topic. The other problem in behavioral, and you touched on it, and we had this problem at Optum, was always around correlation and attribution, right? So when like you're talking to an individual and you're in a pool, right, and you say, well, we had this all the time, right? Every time I would go in front of whatever payer, and I would say like, okay, here are my results, they would say, I remember one payer was like, well, with all due respect, like I changed the network rate to the hospital. Is that what's driving the savings? How do I know it's you guys? Okay, so you have to get in that argument. I think the first thing, though, to get to your question, and Jeff kind of hit on it, is like, and I'll give you a quote, and then I'll stop talking. Dick Migliori, who is the CMO of United Health Group, said this in a speech, a forum that he was in, and I'll never forget it. He said, the last time I checked, God hadn't separated the head from the body, but that's exactly what we do in medicine. And it has resonated with me. That was 10 years ago, and I've said it as much as possible. So we have got to appreciate that, and we've got to measure that way. Like, we should not measure behavioral health. We should not measure physical health. We should measure health, right? That's the change. I think if you can do that, you get rid of this attribution problem. You get rid of the correlation problem. You can start to measure outcomes, hopefully based upon the delivery of evidence-based guideline.
And I would add to that, I think that in thinking about outcomes and in our value-based relationships, it's primarily been to this point the PHQ-9 and the GAD-7, and from a provider perspective, those two assessments are great, but they don't always give the full picture of what's going on for that person, and it's a point in time when they take that assessment and may not reflect the full pathway that they've gone through in terms of care and all of the strengths that they have and the gains that they've made. And so really kind of thinking about it from a whole person perspective, as you're talking about, and also thinking about things like the social determinants of health, and really sort of thinking through overall quality of life, which will ultimately result in a reduction in medical spend.
And to add to that, just to pick up also on Tripp's comment, 50% of all mental illness is first diagnosed by the primary care physician. And we know they don't have enough time. So how are we providing a wraparound set of services to support these primary care physicians who are in value-based care arrangements to help that individual? We have to give that support if we're thinking about the whole person to get to the outcome.
One of the biggest barriers, as you're saying, Tripp, the head from the body. Well, our training and our system, that's how we do it. It's like in whatever career you're in, you come to the fork in the road. Mental health, not mental health. And that includes nurses, staff, as well as clinicians, physicians. And so the systems are so separated, including at the medical schools and the people who are teaching the workforce. So the training is not there to do whole person. So that's why the kind of along the continuum is putting behavioral health and primary care and doing team-based care can be the way there. But until, what we're going to get is what we pay for. And so that's still part of the solution. But the separation in our whole healthcare system in the United States is head from the body.
One last thing to add is, we struggle in our field and in our country with workforce shortages, and so if we set up value-based payments in a way where we work with PCPs, as we're describing, to address mild to moderate conditions, and that are completely amenable to treatment in primary care, right? And the majority of behavioral health conditions actually are mild to moderate. And so if we can support PCPs through the collaborative care model, through other models such as that, to address the needs of the majority of patients who have mild to moderate conditions, and then build their risk models and incentivize them through their quality measures around that population, then you take your limited resource of specialized, LCSWs, nurse practitioners, others, master's level clinicians, and MDs, and then you focus that group on the more severe and complex, where we're uniquely trained to treat, and then connect them in and help them coordinate back with primary care. That's how we can build a model where we truly are addressing the full spectrum from mild to severe in an integrated way, and also dealing with the inherent workforce resources that are not going to change in the near term.
Yeah. So if you take it down to the very granular, and we don't need to get caught in the weeds, but the granular specifics of like contracting as we think about value-based care, it sounds like and completely in agreement and alignment that there's a huge component of integration of behavioral health with primary and other specialties. How should we think about that from a contracting standpoint? Will behavioral health ever be a fully capitated specialty that somebody might be able to succeed in? Will there be subcap? Is there just a shared upside, downside, PM, right? There's all kinds of different contracting structures, but I guess the specific question is behavioral health an industry where we might be able to see fully capitated value-based care, or will there always be some component of integration and subcap?
I'll just start. We already are seeing fully capitated models in behavioral health. And so it is, not all providers are at a level of maturity through their, data and EHR and their infrastructure to be able to manage full risk, but some are. And then there's really interesting ways where they're either, and we do this at Author, coordinate across with primary care, or even bring the primary care services into our behavioral health home. And that's a really interesting model that many of us know, where especially for people with more severe and complex illness, if you lead with a behavioral health intervention and a behavioral health home, and then you do reverse integration, bring primary care into that model, that's really been shown to drive outcomes, especially for that more severe and complex group. And that's a really ripe model for a capitated approach.
Yeah, I definitely agree with the point that there's the spectrum on the capitated side. There's also many steps that could be taken beforehand. So, get the right quality measures. Think about, FUH, FUA, FUM. Getting primary care focused on that is part of the model of incorporating and catching these individuals, whether they're coming out of the hospital or out of the ED. Are they engaging and caring about that from an engagement point? You'll now start to wrap that into value-based care. Earlier diagnosis of these individuals, so making sure that the reimbursement model, similar to what we've seen with version 28, allows people to actually take the time, get identification early, so that people along the treatment protocols there can treat this individual, get the information into their EHRs, so that it becomes front and center for everybody that's treating these individuals. I think this is very important in contracting. It has to be written in because it is what everybody plays the game to.
Yeah, I would just say, so again, going back to the payer perspective, at Optum, we tried a couple times. By the way, Kate can attest to this because she was with me during this time. Every single time we had a quarterly business review, this is the only thing the executives want to talk about. How do we go into full risk, and typically on SMI, so severe mental illness, right? And so how could we identify that population and then take full risk on that population, whether it's behavioral or medical? Because I think the question was, can you ever do this in a siloed behavioral model, right? So we would run a bunch of analytics and say, okay, we've identified a population where like 95% of their cost is driven by behavioral needs, and we'll treat the whole person. Basically, we'll take those members on, and we'll start to provide services to them. And my question was always like, well, what do we know with the medical side? Because we're a behavioral health organization. It's like, oh, well, we'll figure that out later. Like, we'll refer them over somewhere. I was like, no, that's not going to really work. But anyways, but the attribution's hard, right? So like we had a bunch of vendors who came and helped us, right? And so it's like, you only get credit if you support these individuals, right? They're on the street. They're on the ground supporting the individuals in the community. It's a Medicaid population. So what happens when someone walks in the door who's not in the attributed population? What are you supposed to do? You're not going to turn them away. So you let them in, right? And you help them. We're human beings. We're clinicians. Like, listen, behavioral health, you all know this. Tons of passion. So you help those individuals, right? Then what happens? Well, guess what? You're not actually working on the individuals that have been attributed to you. You're working on other people who need help. So then you go to measure this stuff, and then like you get in a fight because like half the population wasn't attributed to you, and yet you're treating them. So it gets super messy, and that's why I just think like, to me, it's always about expanding the denominator, right? So the reason I think not only head body, but because if you can think about a denominator, not in behavioral health only, but behavioral health and physical health, the whole thing, you don't have to quibble about like, well, wait a second, like the mental health side took this and the physical health side took this or whatever, like, and these attribution models can get a lot simpler, but we're not built that way, right? I think in the health plan world, we're built in a way that's much more vertical. I think the startups like the one that Kate's running are getting at this, which is great, right? An ability to think about it in a different way. But it's difficult. And the infrastructure, Cara McNulty touched on it today, and we'll get to this, but the infrastructure in behavioral health, the tech stacks are horrendous. No offense if Arkansas is not, by the way. I'm speaking from two plants that I was at and that she was at. And so you're only as good as the technology that supports you, right? And I think you said it when we started, mental health tends to lag physical health, and so that's always a challenge too. I'm not trying to be, by the way, I feel like I'm doom and gloom on this one, but I do really believe this is doable, but I think we have to just look at it in a very different way, and I think both Kate and I tried to get that over the hump at United. I think we both would say we measure ourselves on outcomes, hence why you find us at other firms right now, because we able to pull it off. We tried.
I think we did great.
We tried. But I do think that that's the way to go, and that's how you contract. You don't contract like uncapitated full risk arrangement for mental health. You have to consider the whole body.
Well, and to sort of add to what you're talking about, I think from the startup and provider perspective, we are really trying to cultivate a community of practice for individuals. And, we may not integrate primary care, have primary care physicians come into, our team, our full-time team, but we are really leveraging the technology to be able to communicate meaningfully with primary care groups and health systems and really partnering with them so that we are creating this experience for the member where they feel really supported by everybody on their team. They know that they're all communicating and speaking, and we're really kind of helping each other out in supporting that individual in their care journey.
So I'm looking at the clock. We probably have time for one more question, and then we'll open it up to the audience. But for those in the audience that we've got startups, payers, providers, we've got all of it in the audience. Each of you have experienced value-based care and behavioral health in a different way, and you're bringing a different thing to the table. Practically, what are some things that you guys have learned, whether it's from the payer, provider, startup side, that some folks in the room might be able to apply to their day-to-day to help either move the ball further down in value-based care, or things to avoid, or things that you've learned that we might be able to pass along to some of these individuals?
Sure, I could start. So from the startup perspective, I think, and I've sort of heard this as a theme this week as well, many health plans struggle to want to engage in that value-based conversation when you haven't had enough volume with them yet serving. And so for us, it was about going fee-for-service in some markets to really get that data and develop those relationships, but also finding really strong partners that were willing to kind of innovate and think outside the box in terms of value-based arrangements. And so we've had a lot of success with the Medicaid population in a number of states that we're in, working in a value-based way where we're working very closely with the health plan. We determined outcomes together and what was going to be meaningful to them, but also to us. And we meet on our regular cadence to talk about what's working, what's not working, what are the roadblocks. And it's really a partnership that has allowed for all of our interests to be sort of attended to, and ultimately it's allowed for clients to get the care that they needed and to break down barriers to access in some of the more rural areas of the states that we're in, and really allowing for them to drive their journey, whatever that looks like for them, with the support of their plan, with their provider, and their community.
That's great. I'll hit on probably two things. One is being very crisp about what value you're driving. And we talked about this in the earlier panel that we were on. Not every patient population for behavioral health drives medical expense savings. Like there are certain groups that aren't, most of medical expense savings, right, is for patients where they have co-occurring physical health conditions that are driving ED and inpatient utilization. There's lots of groups of people who are otherwise healthy, so think about young adults with new onset depression, children and youth, where there's not a medical expense savings opportunity. And so it's really important when you're pitching to a payer to really think about, from their perspective, how are you driving value for them? It could be in sales. Are you doing something that matters a lot to employers? And if you're pitching to a commercial payer, that's going to make them sticky with employers. Is it within Medicaid? Will it make them more competitive in a Medicaid bid? So I think those are things to be really thoughtful about, like what value are you driving? The other is quality measures, which we can talk about. There's lots of quality measures in behavioral health. Trying to pick ones that are clinically validated and are widely used is really important as well, so that you're easily able to align with the payer on what they're measuring for their patient population and argue that through your solution, you're going to drive outcomes on these measures that matter to them.
Yeah. Oh, go ahead. We'll go right down the line. Go ahead.
Right. And kind of along the same lines what Jill was saying is that I think it really goes back to relationships. Instead of drawing up a perfect plan from the payer side or from the startup vendor side, you've got a solution and then trying to impose it, to really work with the different providers and be very transparent, because there's just a lack of trust between people selling things to the payer selling things to the providers, and selling it to the patient's members. So I think the more transparent, authentic, say what you can't do. I'm always more encouraged when I'm asking someone questions, well, can you do this or do you do that? And they say, yes, I can do everything. But as soon as they say, no, we don't prescribe ADHD meds, or no, we can't see people that come straight out of the hospital, saying no to whoever you're trying to sell to is going to be important. So authentic and honest. And also, if you are selling, if your technology, make sure you've got the technology people who are the experts. But if you're selling some sort of clinical process, make sure that you get the clinicians on board early. Because what we're seeing is a lot of the developers are bringing some great sales plans to us, but then the devil's in the details in terms of the clinical implementation. So get your clinicians on board early.
That's great. Two or three things just quickly to add. One is, if you're looking to drive great outcomes, think about synchronous engagement with these individuals. The studies are showing that the sooner you can actually engage these individuals, the better, ideally within 72 hours of an incident. So claims is too late. Think about real-time moments, whether that be a primary care physician making a diagnosis for mental illness, someone's been admitted or discharged. Try and take advantage of those pivotal moments that are happening in these people's lives and get them engaged. And the other piece I would just add is, think about not only initial identification, but the more you can actually create almost like a moments machine, and seeing these moments occur throughout the whole ecosystem to re-engage individuals who might have fallen off their care plan. Because it isn't just about the upfront engagement, it's also about, are they coming back and regressing, and making sure that you engage with them. So those are the points I would add.
I'll be like super tactic driven. So from both the startup and the payer side, and I mentioned this before, like everyone has a different definition of what value-based care is and what that means. So if you're going to, and every time I ask someone, like, we start talking to a company, and I'm going to go into a value-based arrangement with, name the plan, Cigna, I'll make it up. or whatever. Fine. So my first question is like, so how big is your actuary team? And the answer is typically like, what? I'm like, so who's going to measure on your side the outcomes that you're saying you're going to deliver? Who's your team? Because let's be very clear here. Like, you're going to walk into a payer and talk about a value-based arrangement, and you're typically sponsored by someone on the business side who gets very excited about your offering. The actuarial teams in health plans are designed to prove that your solution does not work. Right? I saw Martha somewhere. Martha, there she is. We talked about that. Martha has got a deep history in mental health. She ran off to Behavioral too. I'm not saying that that's like a check and balance system, right? You have a business sponsor. Oh, this is amazing. The actuaries and health plans are basically there to prove it does not work. So you have to be on your A game. And if you walk in without a team that knows what they're doing, you're going to get crushed. Right? That's the first thing. So my first thing is like, if you're going to say a value-based contract, you better know how to measure it. Second thing is like, don't be afraid to say, how do you do it? Because the reality of the plan side, right, is they've done this. I used to say to my team all the time, like, we're not reinventing the wheel. The wheel's been invented, right? I was doing ROI analyses of the first company that Liam and I ran, that I was at in 2000, 25 years ago, right? These health plans have figured out ways to measure the impact, whether it's mental or physical health. Typically, the way they measure it is because that's the way they can measure it based upon the system inadequacies they have, right? And so think about it this way. You guys are speedboats, the startups in here. You're speedboats with 2025 engine and capabilities. The plans are typically massive, huge, rusting oil liners from 1972, okay? You guys are coming in and saying, like, this is what we want to do and this is how we want to measure value. And the actuary teams and others have figured out, like, this is the way that we have to be able to measure it because this is how I can pull data and see if it's legit. So there's no reason to walk in there and not say, like, okay, listen, you've done this before. How do you measure like the outcome of the service like mine and have that open dialogue, right? You heard that yesterday, I think. Andrew said it from Northwell, right? So, sorry, from Cigna. So anyways, but I would highly recommend that you sort of take, you take like I know what I'm going to reinvent healthcare and measure it this way and just ask the plan how they do it. And you guys can come to a common agreement. And I'm telling you right now, it's going to help you on the back end because you're all going to be able to measure something and then have a team that's going to help you measure it. Because I've seen many, many companies who get so excited by value-based arrangements and they're out of business because they bet the farm on it and they don't know what they're doing. So I beg you, because let me tell you, this room is where the innovation happens. The innovation happens from the motorboats, I think, right? And then health plans try to adopt it. So I think we all want you to be successful. I want Kate to be highly successful, right? But you have to, if you're going to go in these payment arrangements, you have to know how to measure it and you have to be aligned with the plan.
I like it. That's helpful. Hopefully folks were taking notes. We have, it says 6 minutes, so we've got time for a couple questions. I think there's a microphone here, but it's a small room, so. All right, go for it.
So let me just make sure I understand the question. How are we getting patient-centered care incorporated with the health, like how are we getting health plans to buy into that? Right. Right. That's right. Money, right. Yeah, I think there's two things, and so one is the timeliness. So thinking a lot around what are those moments when, especially around behavioral health, when patients are wanting to engage in care. And so it's those times, right, if someone's in crisis, right, or if they've just left the hospital or an ED, or maybe there's something else that we can pick up that's going on in their lives where we could know that this is a time when this person's ready for change and ready to engage in care and try to capture at that moment. The other is really emphasizing relationship. And so as you all know, a lot of the patients that we treat have a heavy burden of health-related social needs. Lots of times their health care and their behavioral health care is not number one to them. And so any ability that we have to first align on what is the most important to that patient, oftentimes it is the health-related social need first, form the relationship. Then when there's an exacerbation, there's sort of rising psychosis or exacerbation of substance use, you're right there with the clinical team to intervene at that moment, and they're ready to engage because they have the relationship and the trust.
That's exactly what I was going to say too, is build a relationship with the primary care provider, whether it be family practice, pediatrician, or OBGYN, because that's the person that the patient trusts the most and they can be going back and forth to. And a lot of times these plans are being built and aren't including the PCPs.
And I would also add, we hear a lot from, clients that come to us for care that they, feel very judged related to their behavioral health needs. And, they've been through treatment before. It hasn't worked for them for a variety of reasons. And so really meeting the person where they're at, understanding what their past experiences with treatment have been like, and really sort of aligning with what their goals are, what their best life looks like, and sort of being the guide through that process has been a really important in terms of engagement for us.
That's great. Any other questions? No other? Go for it.
Hello, my name is Andrina. Thank you. Hello, my name is Andrina. I'm from Sycamores in California, a nonprofit organization that focuses on mental health for youth and adolescents. I currently run our research and continuous improvement department, and so we do a lot of in-house research on different outcomes such as PSC, CANS, some of the measures that you've also mentioned. And my question is really more about getting more in the nitty-gritty of what outcomes. We talk a lot about better mental health outcomes, but what exactly are they for your organization, for your agency? What are maybe the top ones that you focus on that have driven your success?
Sure, I'm happy to go first. We're tracking a lot when we're working with members. So we're tracking, clinically validated standardized assessments. We're also looking at, I think I mentioned before, the social determinants of health. We're trying to really understand the whole person and environment, and really trying to align the treatment in a very personalized way to support success. But in terms of outcomes that we've seen in some of our health plan partnerships, we've seen an 85% engagement rate with the Medicaid population that we're working with through some of the strategies that we've sort of talked through. We're also seeing over 90% reduction in GAD-7 and over 80% reduction in PHQ-9. And we're seeing a huge reduction in ED and inpatient stays. So that's kind of been our focus with this particular partnership and some of the successes we've had.
Yeah, I'll just say, and I heard, and I'm friendly with Taft. Yes, I know many people heard him speak yesterday. So I wish I didn't have to say this, but I'm going to say it. A lot comes down to return on investment, and it comes down to cost savings. And it part of me feels it's unfortunate in mental health. That's just the reality of the world, right? And I'm a big fan of, like, you got to understand the reality of the world, right? I wish that wasn't the case. I wish we didn't have to think about increasing utilization management and costs as we help someone with severe mental, or any kind of mental health issues. But that's the reality of the payer world. And let me be very clear. So running Optum Health, I would have executives within United. By the way, the same is all plans. So I'm just picking on United because I was there. But whatever plan it is. They're on stage. You will not find a single executive of a major health plan who doesn't declare mental health a really, really serious problem in our country, period, right? It is a sweeping epidemic. They will not get they'll have 1, 2, 3. They'll get on the second stair, and I'll get a phone call running mental health and say, why the hell is your utilization going up so high? Cut cost. So there's a paradox that we're facing in this payer world, which is care is needed. And I don't think, by the way, that curve's going down. Because there are lots of cohorts of patients that are not appropriately treated today, and there's a lot of stigma still left, even though we've come a long way with stigma. That curve is going to keep going like this, and you're going to continue to have organizations to say, I need you to get your utilization under control. Plain and simple. So I hate to say it. It kills me at my core. But the reality is that if you can't demonstrate some kind of impact on cost, I don't know how you engage in a conversation.
And I agree with everything Tripp said, and I think it's important for us all to realize, too, that just like in value-based care, you're going to see primary care use go up. You're going to see behavioral health costs go up. But you should be able to then demonstrate the PMPM savings that decreases in terms of hospitalizations, rehospitalizations, and care, and you need to be able to describe that message. It's just logical. It's going to happen. You're getting the right care for the right person at the right time, and it will have downstream impacts, but you need to be able to make that connection, as Tripp was saying.
Good. Go for it.
Yeah. No, I agree. So you're saying, can you speak more typically to youth? Because the cost savings, right, assumes that there was high cost. And most youth, it's very unlikely for a youth to be sick at all, much less have more than one condition. And so that is where it is very challenging to demonstrate cost savings, and that's where we've got to think through how we change the conversation. Again, are there other drivers of value? Again, are you more competitive in a Medicaid bid? Are you more competitive with employers? If you're offering a digital solution, do you have an offset from live therapy? Like, is there a way that you're offsetting the need for live therapy? So I think there's these other pockets, but it's really challenging in those examples.
Yeah, and I'll just say one last thing. I know we're ending. This is something that I think scares me a little bit, right? So I was just reading an article last night, and I wrote down some of the stats, and especially with this new administration that's coming in. So when you talk about collaborative care models, I mean, that collaborative care model is going to be under a lot of pressure right now, right? So CCMI, which administers this program, right, I think I wrote down 49 models. They've only allowed, quote unquote, the expansion of 5. Now there's reasons for that. I think that the bar is set too high on how you measure outcomes. The CBO, Congressional Budget Office, comes in and says, well, what's the savings impact of these models? Guess the savings impact was? It cost $5 billion to the system. So if you're an administration coming in and you see that number, you're going to be like, what the hell is going on here, right? Especially a new administration. And that concerns me, right? Because again, unfortunately, they're going to start looking at these cost factors, right? And so like that number is high, and there's reasons that number is high, but it's going to come back to, I think, like if we're going to provide this care, and youth comes up all the time, by the way. Like it is huge, it's impactful, I get it. But we're so driven by costs in this society, and unfortunately, to me, it's a massive paradox. But I would be on the lookout for what happens with the collaborative care model and CCMI under the new administration, because that number is big.
Yeah. Well, we're already in overtime, so we'll wrap up here. But give our round of applause for the panel. So thank you.